The study was conducted between 2006 Surgical Unit, March 4, 2023, and Gastroenterology Department and Medical Ward 4 of Dr. Ruth K. M. Phao, Civil Hospital Karachi, along with Medical Unit 2, Dow University of Health Sciences, Campus, Karachi. Written consent was taken from all patients. All details about the patients were kept confidential. Introduction. Esophageal variceal bleeding is one of the most serious complications of liver cirrhosis with portal hypertension. The risk of bleeding varies between 835% within 2 years of follow-up. The risk of first variceal bleeding is related to the size of varices, degree of liver dysfunction, Child-Pugh score, elevated hepatic venous wedge pressure gradient, HVPG, and the presence of mucosal red signs detected during endoscopy. 2. Despite the fact that mortality has been significantly reduced over the past 2 decades thanks to advanced intensive care, vasoactive drugs, and endoscopic therapy, the 6-week mortality rate is still very high, 17.5%. 4. Primary prophylaxis of first variceal bleeding is therefore an important therapeutical goal. Several randomized studies and meta-analyses have shown that non-selective beta-blockers, propranolol, nadolol, decrease the risk of bleeding by 4,050% as compared to placebo with a trend toward improved survival. 226. However, the use of beta-blockers has several shortcomings. The treatment is associated with numerous side effects in up to 40% of patients. 7. And reduction in portal pressure is not adequate to prevent bleeding in 30 to 40% of patients. HVPG less than 12 mm of mercury or a reduction by 20%. 8. Also, rebound phenomena with an increased risk of bleeding following sudden cessation of therapy. 9. Make lifelong therapy necessary in the majority of patients. Contraindications preclude the use of beta blockers in about 15% of the patients who are considered for this treatment. 10. No other alternatives to non-selective B blockers exist for pharmacological prophylaxis of variceal bleeding in routine practice. Endoscopic therapy, either endoscopic variceal band ligation, EVBL, or sclerotherapy, are highly effective in both the management of acute variceal bleeding and secondary prophylaxis. 11. Sclerotherapy is not recommended for primary prophylaxis because of inconsistency of results across trials. 12. EVBL has been shown to decrease the relative risk of first bleeding by 64% and mortality by 45% when compared to no treatment. 13. EVBL has been compared to beta blockers in several trials with inconsistent results. 14.2. 19. EVBL was superior to beta blockers in 2 randomized trials. 22. 21. But a reduction in mortality was observed in only one of them. 21. Furthermore, 2 prospective control trials were prematurely terminated for different reasons, one because of excess bleeding in the ligation group, the other for high treatment failure in the propranolol group. 21.2. 22. The latest trial reported a lower rate of esophageal variceal bleeding in the EVBL patients. 23. Thus, the results of the available studies must be interpreted with caution, and a recent consensus workshop recommends EVBL be offered to patients with medium or beta blockers instead of beta blockers, large varices and contraindications or intolerance to beta blockers. 24. To further elucidate the role of EVBL in primary prophylaxis of variceal bleeding, we conducted a prospective, randomized, multi-center trial designed to compare EVBL with propranolol treatment. 1. Non-cirrhotic cause of portal hypertension. 2. History of gastrointestinal bleeding of any origin. 3. History of sclerotherapy EVBL or portosystemic shunt. 4. Documented malignant disease. 5. Gastric or duodenal ulcer. 6. Congestive heart failure. 7. Chronic renal insufficiency with plasma creatinine 150 mol/L8. Treatment with beta blockers, nitrates, ACE inhibitors, or verapamil within 2 months before randomization.
Multi-band ligator handle, loading catheter, irrigation adapter, barrel with preloaded bands and attached trigger cord. We have 6 specifications: 4 bands, 5 bends, 6 bends, 7 bends, 8 bends, and 9 bends. System preparation. First, examine features of handle. It has 2 positions which control rotation. Firing position allows handle to be rotated in forward direction only. Two-way position allows handle to rotate in both directions. Prior to introducing endoscope, keep handle in two-way position. Second, insert handle into endoscope accessory channel, following instructions for appropriate endoscope. Third, introduce loading catheter through wide sealing handle and advance in short increments until exits tip of endoscope. Fourth, attach trigger cord to hook on end of loading catheter. Withdraw loading catheter and trigger cord up through endoscope and out through handle. Fifth, attach barrel to tip of endoscope, ensuring barrel is advanced onto tip as far as possible. Sixth, with endoscope tip straight, place trigger cord into slot on spool of handle and pull down until knot is seated in hole of slot. Seventh, with handle in two-way position, slowly rotate handle clockwise to wind trigger cord onto handle spool until it is taut. Eighth, check endoscopic view. To maximize visualization, position of trigger cord may be altered by rotating barrel.
Nine, concomitant antiviral therapy. 10. Hypersensitivity to propranolol. 11. Atrioventricular block of grade 2 and 3 sick sinus syndrome bradycardia under 60 beats/minute. 12. Asthma or chronic obstructive airway disease. 13. Decompensated diabetes mellitus. 14. Pregnancy or lactation. Randomization to EVBL or propranolol therapy was done at each center using a computer-generated table of random numbers. Patients were followed for up to 18 months or until liver transplantation or death. The primary endpoint was the number of variceal bleeding episodes. Secondary endpoints were: randomization to EVBL or propranolol therapy was done at each center using a computer-generated table of random numbers. Patients were followed for up to 18 months or until liver transplantation or death. The primary endpoint was the number of variceal bleeding episodes. Secondary endpoints were: 1. Death due to variceal bleeding, underlying liver disease or any other cause. 2. Gastrointestinal bleeding from any other origin than esophageal varices. 3. Evaluation of portal hypertensive gastropathy. 4. Side effects and complications of EVBL and propranolol. 5. Recurrence of varices in the EVBL study arm. Endoscopic variceal band ligation. Patients assigned to the EVBL group underwent ligation after an initial screening gastroscopy that was performed to assess the size and appearance of esophageal and gastric varices and portal hypertensive gastropathy, PHG, and to exclude other lesions such as ulcers and tumors. The intravenous administration of 5 to 10 mg of diazepam or 2.5 to 5 mg of midazolam was used for sedation on individual basis. EVBL was performed within 1 week of randomization using a multi-band ligation device. 6-shooter SIAG-owned multi-band ligators, and up to 6 bands were placed per session beginning in the distal esophagus just above the gastroesophageal junction. Procedures were performed at 2-week intervals until esophageal varices were eradicated. Variceal eradication was defined as a complete disappearance of varices, or the presence of a varix being too small to be ligated. The interval between sessions was prolonged by 1 week if post-ligation ulcers were present. EVBL was performed by 1 or 2 experienced endoscopists